Hi, good afternoon, everyone. I'm Emily Barson, Executive Director of United States of Care, and it's my pleasure to welcome you to this webinar, The Material and Human Costs of COVID-19 on the 50 Plus, sponsored by AARP. We're so grateful to have AARP as our co-host of today's event. And to introduce our guests, joining us as co-host is Bob Stephen, AARP Vice President for Caregiving and Health Programs. And on our panel today, we have Joanne Grossi, who is a US of Care Voices of Real Life member and Pennsylvania State President for AARP. Jody Prohovsky, an experienced healthcare leader and caregiver. Lee Purvis, Director of Healthcare Costs and Access at AARP. And Dr. Tony Esselin, New York Market Medical Director at City Block Health. They'll each share their unique perspectives on the topic, and I can't wait to hear from each of them on the panel today. After all of our guests have presented, we will open the floor for Q&A. You can submit your questions through the Q&A chat at the bottom of your screen. And before handing it off to our panel, I'd like to share a bit about United States of Care and our recent work. United States of Care was founded in 2018 around the simple yet bold mission that everyone should have access to quality, affordable healthcare. And our goal, our contribution towards that broader mission is intentionally twofold. First, to expand access to quality, affordable healthcare in the near term, because we know that people can't wait for a perfect solution that may be years down the road. And the ripest opportunities for this near-term approach are often at the state level, where we can help advance policies that help people now and build the evidence and momentum for broader change down the line. And second, to pave a path towards durable, people-centered federal policies that achieve our mission. Because we know actually working to ensure access to quality, affordable healthcare will require federal action. And in order to make those policies durable, that will need to work now to build the political will and shift the narrative around healthcare to make those changes into a political imperative. Our mission has never been more important than in the current COVID-19 public health crisis. And we know that it isn't enough for us to weather the crisis and go back to normal, that we need to build a better, more equitable healthcare system in the wake of the pandemic. Durable solutions in response to the pandemic will only be possible if we're centering those solutions around people's shared needs and engaging people in the conversation. To better understand those needs, we've undertaken an ongoing listening project, combining a survey of Americans, in-depth interviews, continuous analysis of public opinion polling related to the impact of the pandemic on the health and healthcare landscape in the United States. And these components have helped us to understand what Americans are concerned about regarding the pandemic and how the healthcare sector should be shifting to address those concerns. Recently, we published a guide at United States of Care to humanizing the healthcare debate and the COVID-19 response based on that listening work and our expertise in healthcare policy. I'm going to briefly share some of those findings today, including specific analyses for the older Americans. After months of ethnographic interviews, in May of 2020, we surveyed over 2,000 people across the country with an oversample for African American women, Republican identified men and women, and Republican identified high school educated white men. For this presentation, we're highlighting specific data on the responses from older Americans. Our research sought to understand how people are doing, their worries, concerns, and needs, as well as what matters most to them and how they're feeling about the healthcare system. Contrary to the current national conversation, our findings show that many people share common and in some cases heartbreaking experiences, even if we each have unique circumstances and inequalities and different political viewpoints. In several of our surveys' open-ended questions, people gave similar responses across a variety of demographics: Republican and Democrat, rural and urban, African American and white. I will dive into those today before turning it over to our other speakers. And before I share the findings, I want to share a reflection. At first, these findings may seem remarkably obvious. When we share this work with others, we see head nods of agreement, reflecting on how we all are feeling throughout the day. Anxious, concern, worry, mixed with hope and gratefulness, thinking about our loved ones and about our country, our economy and our wallets, about our individual and shared future, and concurrence on the priorities that our healthcare system should focus on. We wondered when we share our findings if the obviousness of them would undermine the usefulness of this work. But we soon realized a disconnect from the national discourse and our findings. We aren't actually having a national conversation which reflects what we've heard from people in our discussions and in our survey. While we watch the news of partisan fights over the backdrop of human loss and a cratering economy, a run up to the election, as we're neglecting to identify what we all have in common right now and which differences are noteworthy. And while I don't pretend there aren't true differences occurring at all angles, different health needs, financial needs, partisan differences, it is our intention with this research to nuance the national discourse in a way that resonates with people and humanizes the response to the pandemic. In our ethnographic one-on-one and small group discussions and our survey, we first just asked, how are you? And really what we saw was that Americans are feeling a mix of emotions related to the pandemic, and those emotions are overwhelmingly negative. The highest percentages of respondents feel concerned, anxious, uncertain, and frustrated. Primarily, older adults were concerned about catching COVID-19. Some raised this concern directly about themselves and their status as a high-risk group, while others expressed concern about their family or friends becoming sick. But Americans, including older adults, are also finding hope in the midst of this crisis, in religion, in their families, and in stories of people helping others. We also asked about people's top concerns. And across the board, when asked to rank different concerns, we found that the public is deeply concerned about their health and financial well-being, reflecting an interconnection of these parts of their life and broader society. In open-ended responses, a significant number of respondents are putting concerns about their loved ones ahead of themselves and are concerned about their community and those on the front lines. Finally, we asked people what they need from the healthcare system. Across all demographics, shared needs are emerging in response to the pandemic, including the desire around 4 specific needs. First, a reliable healthcare system that is fully resourced to support essential workers and available when it's needed, both now and after the pandemic. Second, a healthcare system that cares for everyone, including people who are vulnerable and those who are already struggling before the pandemic hit. Third, accurate information and clear recommendations on the virus and how to stay healthy and safe. And finally, being able to provide for ourselves and our loved ones, especially as we worry about the financial impact of the pandemic. When asked to rank needs that were most important to them, older Americans are fairly evenly divided on these needs, including the healthcare system that values human life and cares for the most vulnerable, a healthcare system that is resourced to support frontline workers, and accurate information and recommendations. You can check out our guide on humanizing the healthcare debate and more of our work on the COVID response on our website at unitedstatesofcare.org. And we have resources reflecting these results, including policy recommendations that we made to state and federal leaders grounded in the needs that we heard from this listening work. And now I am pleased to hand it over to Bob Stephen from AARP. Bob?
Great, thank you, Emily. You know, we've all faced unexpected costs and losses due to the pandemic, and I know, the great information that Emily shared really gets to that. You know, we've been working from home, balancing kids and their virtual learning in some cases, supporting and caring for their loved ones, minimizing the time that we have for our friends, and feeling really anxious about every step that we take. And we could really go on and on. But you could really argue that the 50 plus population has been hit particularly hard by the pandemic. We hear that as we talk to our members and the 50 plus at large, the stress and anxiety from health risks that could lead to an early death from COVID complications for themselves or their loved ones is a lot to carry every day. And 7 months into the global pandemic, the situation continues hitting family caregivers, those who are providing unpaid care for friends, family, parents, spouses, even harder, specifically women in particular. These women are already doing double duty. taking care of their aging family members while raising their own kids. And the majority of them, over 60%, are working full-time jobs. And while almost all of us have been trying to do the nonstop juggle of work and life balance, some, more specifically these women that I mentioned, are having to leave the workforce completely. As we published with S&P Global just a week ago, and the number's been out there, 865,000 women left the workforce in the month of September. And obviously that decision will have a long-lasting, devastating impact on future career and financial earnings, particularly for those who are over the age of 50. But it's not just women who are stressed and having to make these drastic decisions to survive. All family caregivers, and I want to make sure that I point out that family caregivers range from in the the Gen Z all the way up through boomers and the greatest generation, but over half are over the age of 50. They're already stressed prior to the pandemic. And in the research that I just mentioned, we find that during the pandemic now, 75% of family caregivers say that they are more stressed now than they were prior to the pandemic. And further, over half of them are spending more time on their care responsibilities now versus prior to the pandemic. ARP has tried to put a much needed spotlight on the needs of the millions of Americans who care for their aging parents, spouses, and other loved ones. We've been actively advocating for transparency and virtual visitation from nursing homes across the country, particularly during the pandemic. And we've been continuing to push our efforts to lower prescription drug prices and costs, helping family caregivers address their mental health needs, and helping employers make their workplaces more caregiver friendly. We now have a chance to seize this moment. As Emily really drew out in the data that she shared with what consumers are looking for. We have a chance to seize this moment to create meaningful long-term change in our care system. The work of family caregiving is just one aspect of that, and it's you say the caregivers are the backbone of our long-term care system in the country. Caregivers and the care that they provide is also vital to reviving our national economy. There are many hard and soft costs that the pandemic is amplifying. Your mental health, your finances, your own physical health, and the future of your career. And I know today we're going to really be focusing on the financial, emotional, mental, and health strain from the pandemic among those 50 plus. Now, ARP is proud to sponsor this virtual event and to shine a bright light on these issues. We're fighting to address the concerns of the 50 plus in our state and federal houses across the country, and to equip families with the much needed information, resources, and support they need to be an advocate for themselves and their loved ones. And that we've doubled that effort during the pandemic. And I would cite if you're looking for more information, particularly those things relevant to COVID and the pandemic, please go to arp.org/COVID. I'm happy to be here with my colleagues, Lee Purvis and Joanne Grossi, who is our ARP Pennsylvania State President, as she mentioned. We're looking forward to a great and thoughtful discussion with all of our speakers. And finally, I definitely want to give a great big thank you to US of Cares for all they do, and in particular for pulling together this great webinar. And now I'd like to turn it over to Joanne.
Thank you, Bob. And your comments were, so relevant because I'm one of those women you were speaking about. So perfect segue. And good afternoon, everyone. I'm really happy to be with you. And I'd like to speak to you for a few minutes on two perspectives regarding the emotional and financial strains on the 50 plus population during the COVID pandemic. First, from a general and then from a personal perspective. So regarding the general, ARP Pennsylvania actually conducted two polls, one in September and one just last week on this issue. And I thought two of the results were really striking. First, 58% of respondents told us that they had to contact a creditor to seek relief from paying a bill they couldn't pay. So you see the financial strain on these respondents. And second, in our October poll, 62% of respondents told us that they were worried about getting the coronavirus. And that was an increase from the 55% in our September poll. So it demonstrates that anxiety is increasing among older Pennsylvanians regarding COVID. And just an interesting aside, 22% told us that they knew someone who had died from COVID-19. And I'm actually one of those 22%. So it's clear that older Pennsylvanians are experiencing real financial and emotional strength from the pandemic. On a personal level, I am a caregiver for my 90-year-old father, and we have both certainly felt the emotional strain from the pandemic. First, my father fell in late May, and I had to take him to the emergency room. And so I really got to experience to some degree what a lot of other families are experiencing, because when I brought him to the emergency room, I had to leave him there. I actually had to talk my way into going in to a certain spot in the emergency room and speaking to a doctor, because my dad, on top of everything else, can't hear, even with hearing aids. And so I knew he wouldn't be able to answer the doctor's questions about what happened to him. So I literally had to beg my way in to be able to speak to a doctor, to tell them what happened to him, and to give him, some list of medications and give him some information. But after that, they threw me out of the emergency room, and I literally sat outside of the hospital for 8 hours while I waited to find out if they were going to admit him, what their diagnosis was, et cetera. And so then they actually did admit him, and he was in the hospital for 3 days. And so I also got to feel that frustration and fear and anxiety of not being able to be with my dad while they were doing these tests. Again, he can't hear, so I knew conversing with the medical staff was going to be very difficult. The only way we could find out what was going on was by calling and hoping we could get a doctor, for an update. And then, we found out things, we would call my dad to speak to him, and we'd find out, for example, they didn't feed him, and all things like that would have been handled if we could have been with him. And so I got to experience really firsthand what it feels like for these people who've had to drop off a loved one with COVID, and never get to see them again. Because I can tell you, when I had to leave that hospital that day when they admitted him, I really worried, is that the last time I saw my dad, and I didn't get to say goodbye. And I get emotional about it, as you can tell, and he actually turned out to be fine, but it really gave me an insight into what some of these families have gone through. In addition to that, for my dad, he's felt the loss of his social connections. Although he's still seeing his children and grandchildren, he no longer gets to play in his weekly poker group with his buddies, and he's very involved with his church, but his church services were canceled for months, and other church activities have been canceled. So again, he's really lost some of his main social connections, and I see the effects that it's had on him. Fortunately, again, he's still seeing his family, and that mitigates the social loss for him, but it adds to the strain for me, as Bob was talking about a minute ago, as I'm now spending time with him almost daily, which is probably spending at least double what I used to spend with him. And that's an emotional and physical strain on me, is I have to fit in the drive to his house and carve out time with him, among my other responsibilities. I'm a perfect example of what Bob was just talking about. But I consider us lucky, as I have a few friends who have parents in nursing homes, and I've witnessed the stress they've experienced by not being able to see their parents for 7 months now. In a few cases, their parents got COVID, and in one case, a parent has died, alone, of course. So I've seen the toll this has taken when you're trying to navigate a parent's care long distance. It has been painful and frustrating for my friends, to say the least. And of course, here in Pennsylvania, 68% of the 8,800 COVID deaths have been in nursing homes. So this has been the sad reality for thousands of Pennsylvanians. So to conclude, this pandemic has been a challenge for everyone, but I think it's clear that there are some unique stressors for the over 50 population. And with that, let me turn it over to Dr. Judy Prohofsky.
Thanks, Joanne. Hello, everyone. My story is not very different from many of yours, and actually, I'm going to say it's rather common today. I am a caregiver. In all reality, it's an identity that seems to have been my birthright. I had great role models of caregivers in my family. My parents were amazing at supporting their parents through devastating illnesses and the end-of-life process. My mother provided her brand of caregiving to anyone she called friend, and trust me, she just called about everybody friend. And my father cared for my mother through her cancer and through end of life. He was compassionate and loving. He received such positive recognition from the professionals working with my mom. It was actually a great source of pride for him, so much so that he has been volunteering at a hospital every week since mom passed until COVID hit. My dad lived geographically close to me for 10 years after mom passed. And then 3.5 years ago, he took the opportunity to move to a senior living community, which happened to be closer to my sister's. So he now lives 1,200 miles away. It was a good move because he was happy to be around people his own age, have activities geared for him. It also allows him to get the most out of his fixed income, and it helps him manage his social anxiety. Then March 2020, right? In comes COVID. My sister, her husband, and her grown children are all working at jobs that do not afford them to work from home, which meant some of her caregiving of dad had to be distanced or furloughed. My dad's building went into quarantine. All activities were shut down. He was let go from his volunteering duties because the hospital didn't want to put the volunteers at risk for illness. At first, he didn't even have a mask or gloves, hand sanitizer. He didn't have anything at home. He didn't know if it was safe for him to go to the grocery store. And quite frankly, he vacillated on whether or not he cared, which of course drove me nuts because I was not there to put a safety plan in place for him. What didn't change was we could still talk every day, but his stress grew, everyone's stress grew, and now I can recognize that even though I tried to ignore it, my ability to employ my usual coping mechanisms were stressed to the max. Again, not unique, but here's a sample of the initial chaos that was in my life as COVID rolled in. Right? All appointments, activities were canceled, which was more of an annoyance than that seemed to require a PhD in logistics to keep track of and reschedule. My work moved to home and I wasn't logistically prepared. My son was moved to at-home schooling, which meant we all were thrust into 11th grade English class. My son, who had inherited the family multi-generational anxiety, chose not to leave the house for any reason for fear of getting COVID. Getting him out of the house, even for a neighborhood walk, has been a challenge. In addition, I'm the president of our local synagogue, and I had to stay on top of state mandates and population safety and find new ways to bring the community together for religious services. Oh, and my job was eliminated. So now I also had to start a new job search. So caregiving for my son, my husband, my community, my father was not fun. Nope, I was feeling downright frustrated. There were moments when I resented being the one that everyone looked to for emotional support and solutions. And I was definitely losing the focus on my own health and wellness. So I had to take a deep breath. I had to remind myself that I am wired to help and that I have handled many crisis situations, both professionally and personally before. So what did I do? To manage through this time, I needed a plan. I do better with a plan. I know it doesn't work for everyone, but when I break everything down into edible bites, it allows me to feel like I have a little bit more control. So not to bore you with the details, but I started to make a list for everything, and I mean everything, so I could stay focused, connect to the right resources, feel accomplished, and most importantly, not lose my cool with those that I love the most. So I had a plan for conversations with dad, things I had to cover to keep him safe, ways to manage his stress, things to stay away from because they triggered a whole bunch of frustration for both of us. And I surely didn't want to snap or make him feel like he did anything wrong. Ways to help him financially if needed, and then tech support for online shopping and Zoom lessons and things that could keep him active. I had to have a plan for my son's school, AP test, summer plans, 16th birthday recognition, driver's license test, and of course, return to school. I had to have a plan for healthcare for the family, doctor's visits, medication refills for humans and dogs, flu shots. I had to have a plan for groceries, cooking, cleaning, laundry activities, projects, and a plan for diet and exercise, and even socially distant socialization, which was also sometimes connected to exercise. So you can see my story is not special. I'm a caregiver who in 2020 got extraordinarily overwhelmed by more than my usual share of chaos. I forgot to ask for help, and I didn't think I had the right to, as many people in my circle were dealing with things that were far worse. But there are resources out there, and we're not alone. When I can talk to others and share my frustrations, my stress, my accomplishments, my worries, it helps me to think outside of my own box, which turns my brain on to new solutions. So I keep regular dates with great friends who help me make more lists. And now I have more capacity to be there for everyone I want to or need to. And I know that they're there for me too. I want to thank you for letting me share my story today. Now, let's turn this over to Lee.
Hi, everyone. Thank you for having me here today. I'm going to take a couple of minutes to talk about a little bit more about prescription drugs, which is an area that Bob mentioned as an area of longstanding interest for AARP. So I'm going to start off with a little bit of level setting that will help explain why this issue is so important to us. And I think the short answer is the prices. I think you've been reading the newspapers over the past several years. You've been seeing some pretty eye-popping prices. And I always like to try to put that in perspective, historically speaking. So about 1990, there was a drug that came out that cost about $10,000 per year, and it caused an incredible amount of outrage. And we are now seeing prescription drugs entering the market with prices that exceed $1 million per year. So we really have seen an incredible amount of price inflation that is having a huge impact on both patients and the healthcare system more broadly. Unfortunately, those high launch prices are really just the beginning. AARP has been tracking the prices of prescription drugs that are widely used by older Americans since 2005, and we have consistently seen price trends where the prices have increased substantially faster than inflation, anywhere from 2-fold to 100-fold. Something else that we've noticed is that everyone has kind of become accustomed to that behavior. And so when you see a headline about a drug price increase, a lot of times people won't think about the fact that that's a price increase on top of a price increase on top of a price increase. And that really does add up over time. So in one of our most recent RX price watch reports, we took a look at those high cost specialty drugs. And we looked at what the price would have been if the price had moved with inflation. And what we found is that on average, the price of one specialty prescription drug would have been almost $50,000 lower if that price had stayed with inflation between 2006 and 2017. So again, these price increases that we've kind of become accustomed to really do add up. Something else we're paying attention to is the pipeline. If you look at the drugs that are moving through FDA right now, a lot of them are drugs that are specialty drugs, ones that I just mentioned with the average price around $80,000 per year. What we're seeing is a lot of manufacturers focusing their attention on things like biologic drugs, which are drugs that are derived from living organisms instead of chemicals, or orphan drugs, which are designed for patient populations of less than 200,000 people, or personalized medicine, something else we've been hearing a lot about lately. But the short answer for what all of these products represent is an opportunity to charge incredibly high prices. And of course, from AARP's perspective, we're looking at the people who are actually using those drugs. And older adults, if you've heard us talk about this issue before, use more prescription drugs than any other segment of the population. On average, Part D enrollees take between 4 and 5 prescription drugs per month, and they often take them on a chronic basis. So when we talk about people who are facing high prescription drug costs, we are not talking about a one-time you're having a bad month kind of situation. We're talking about people who are facing high prescription drug costs every month for the rest of their lives. There's also a common misperception that older adults have resources that will allow them to absorb the costs associated with prescription drugs. Take a look at these numbers. Median income is just over $26,000 per year, and a lot of them have relatively limited savings. So they really don't have the ability to absorb high prescription drug costs today, much less the even higher prescription drug costs that are coming tomorrow. So you would think, given all of that information, that during a pandemic, we would see perhaps some changes. Maybe there wouldn't be as many price increases. As you can tell by these newspaper headlines, unfortunately, that is just not the case. We are continuing to see the prices of hundreds of prescription drugs increasing since January of this year. This behavior, again, as I mentioned previously, is pretty consistent with what we've seen for decades at this point, but it does seem particularly egregious in the context of a pandemic. Even more so when you look at the larger context. So there are millions of Americans who have lost their jobs or their health coverage or both. You're looking at people who are receiving unemployment, looking at people who have lost health coverage, and of course we are looking forward and looking at what could potentially happen with the Affordable Care Act, in which case millions more could lose that health coverage. So this issue really is one that is sad and unfortunately is getting worse because we're looking at millions of people who don't have an income or don't have health coverage or don't have either, frankly, in the context of high and growing prescription drug prices. And it really is just not a sustainable situation. So of course, we're looking at this and thinking, well, what happens next? What happens if we don't address those problems? And I use the word sustainable, and it's very true, both from the patient perspective and from the larger healthcare system. The reality is that prescription drug prices and the costs associated with them are not something that we can continue to pay. I think it's also really important to keep in mind that this is an issue that people feel directly. Not everyone is going to go to the hospital and have heart surgery, but virtually everyone is going to fill a prescription drug at some point and go to the pharmacy and experience the costs associated with WET. And this really is an issue that they feel personally. And again, as I mentioned, if you look at the larger economic context, this issue is unfortunately not going away anytime soon. We are looking at millions of people potentially facing the possibility of not being able to afford their medications. And I think one thing that people may not recognize is maybe not taking that anti-cholesterol drug today would mean several months down the line, you're looking at a much larger heart issue that's potentially even more expensive. So it's really important for people to be able to access and afford their prescription drugs because ultimately their healthcare costs could be even higher down the road. Again, going back to kind of hammering on this is really important. People really do need some level of relief from high prescription drug prices. And we are facing the possibility of some serious problems down the road, especially in the context of this pandemic. So again, incredibly important issue for lots of people. And now for another important perspective, I'm going to hand this off to Tony so she can speak about the on-the-ground provider.
Thanks so much, Lee. Really important topic. So as we've all heard, COVID-19 has taken a lot from all of us. It has taken our freedom to come and go to places we never gave a second thought. Our decision-making has been complicated to the extent that negotiating the risks, benefits, and alternatives for something as simple as going to the grocery store or a walk in the park must be considered. Many of us listening in on this panel likely have a story about someone they knew and loved or someone they know and love that either lost their battle with COVID or are struggling to recover. They are mothers, they are fathers, they are grandparents whose children and grandchildren have their own families. They have their own lives. They are aunts and uncles and sisters and brothers, and some of them live alone and either qualify for services that they are deathly afraid of procuring because of the exposure risk, or they don't qualify at all. Many gamble with the chance of dying alone or with family members at home, with their independence and their dignity, rather than being another COVID case in a cold hospital bed, where if you could see the eyes of the person taking care of you, it would be a luxury. At City Block, we know we need to reimagine healthcare. We need to expand what we care for, and we need to expand the modalities for delivering that care. The majority of our members are over the age of 50, and we recognize that their health is not a matter of one size fits all. We are dedicated to caring for our most vulnerable populations, including those with multiple and complex social, medical, and behavioral health conditions, and who have historically been marginalized by our healthcare system. New York was particularly affected by this pandemic, with the death toll as high as 1,000 deaths a day at one point, with the city reporting half the number of cases statewide. We knew our members were and still are at risk for contracting the virus and also becoming seriously ill from it. So we went to work to make sure we could keep our members healthy and at home and designed a food delivery program. Access to food at the height of the pandemic was a big need, and it was especially stressful for our members who couldn't get to the grocery store safely, didn't have a network to assist them, were experiencing financial hardship due to recent changes in household income, and or needed to stay isolated to minimize exposure. We developed a high-risk courier program to ensure our members had the supplies that they needed to monitor their health at home, with our community health partners and nurses checking in on them oftentimes daily to ensure all of their needs were met. Medications and cleaning supplies and paperwork for applications, and medical supplies for home monitoring, such as blood pressure cuffs and thermometers and pulse oximeters, they were all delivered. We developed a rapid response team of nurses and paramedics with a virtual backing of a physician to go see members with concerning symptoms and manage them in the home so they didn't have to go to the emergency room. In order to respond to the clinical needs of patients throughout the city, many health clinics have turned to virtual health, but this is a technology that many of our elderly need help with, and without that help are effectively denied access. And finally, the mental health toll in our population cannot be overstated. The anxiety of not knowing who has it out on any given time, the isolation, the food insecurity that is already an issue in our elderly was and continues to be exacerbated. Several of our members during this time had stopped going to their appointments even after clinics reopened. There were members that we visited that had orders for imaging and for labs that they had never done because they were afraid to leave their home. And by the time we got to them, some of them were in crisis. No one wants to go on public transportation or expose themselves to a healthcare worker when they have heard on the news about the limited PPE that we're experiencing. If you were lucky enough to survive, you were traumatized by the early and callous discharge that you experienced from the hospitals that were frankly quite overwhelmed. And as a healthcare worker, you were traumatized by the news that your patient or your friend, your family member died alone. We expanded our mental health capacity to help folks with the increased COVID anxiety that many were dealing with on top of their comorbidities. And oftentimes our care teams were the only family that some of our members even had. The folks in our community, to be clear, are not looking for pity or for charity. They want what any one of us would want, and that is the freedom to live in a world where the decisions about their health are not driven by fight or flight, but it's driven by justice. And so for that, I will pass it over to Emily so we can take some questions.
Great. Thank you, Tony, and thanks to all of our speakers and panelists today. There's been a great sharing of the perspectives across the board that we're all experiencing in this pandemic. And I really appreciate everyone joining and especially sharing your personal stories. I do want to open it up. If folks have questions who are participating, you can use the Q&A chat box at the bottom of your Zoom screen and enter your questions. And I'll, start us off. And, Tony, you shared a number of the challenges that your populations are encountering, and I think, really a lot of these overlapping crises. And curious at what policies or how you think the government can be part of solutions that could help, both some of those right now immediate needs, as well as, strengthening for the longer term, and certainly for others as well. But we'll start with you, Tony.
Yeah, great question. I think these are things that all of us are thinking about, right? Like, how can we strengthen the system so that we are not trying to catch people with nets when it's too late? And I think that one of the things that we have to do is we have to think about where we are investing our resources and how we're going to make sure that everyone has access to healthcare. And so we heard earlier that that the ACA is at risk, right? And so that's something that's going to incredibly affect the members that we're talking about, right? The population that we're talking about. If you don't even have access to being covered with insurance, how are you going to even be able to access those services? And so I think we really have to take a close look as to how we are providing healthcare to our population. I think that's an incredible question. And I think that the fact that some people have underinsurance, we don't talk about those folks a lot, right? The folks that are underinsured, they suffer a lot, and they almost are able to get a service. And I had mentioned, we have members that don't even qualify, right? They'll have insurance, but they won't even qualify for extra services depending on some bureaucratic loopholes that stops them from being able to get access to all the full gamut of services. So I think we really have to think about, from a governmental perspective, what are we trying to do with our population, and how do we want to support them and make sure that health is actually supported as a human right as opposed to a privilege, and it shouldn't be. It should be access for all. And I think that's where we have to start the conversation.
Great, thanks so much. Would any of the other panelists like to chime in with your thoughts on that? Great. Well, we'll continue. We've got a question from a participant. What creative and safe ways how are you seeing older adults fulfill their social needs, and how will these be impacted by winter? And do you have any other recommendations? Joanne, I know you spoke a little bit about this with your dad. Do you want to start?
Yeah, I mean, I don't think I'm going to say anything that's earth-shattering, different than what people have thought of. I know for my dad, even just, doing FaceTime with his great-grandchild, who lives in Virginia, that's really important to him. We make sure we do that weekly. So, he can get to see her, and see how she's developing, even though he can't be with her. And I think, unfortunately, given his age, he's 90 years old. Can't do FaceTime with his friends. They don't know how to do it. No matter how many times we've told my dad he can't do it if we're not there, and his friends can't either. So it's funny. There's some things that technology can help when you're really elderly, but I think there's some limitations to it. But obviously all the things that you would think of, making sure you're calling and checking in. We even have some people who will like drop by food and leave it outside. Some neighbors or family friends who won't, take the risk of exposing him, but certainly will leave some food outside his door or call him. And, again, checking, the church actually checks in with him a lot. They've got a system set up where they check in. And even one of the things we're doing, and then I'll turn it over to someone else, but even one of the things we're doing at ARP in Pennsylvania that I really like, we've gotten volunteers who now can't do any outside activities. We have them actually calling people who used to go to senior centers. So we've actually kind of gotten all of our our volunteers and got lists for them we partnered with the Pennsylvania Corporation on Aging, and we got lists of people who actually normally go to senior centers who can't go now. So our volunteers are actually calling them. So, I don't think these are any ideas that maybe no one else would think of, but there's definitely ways to make sure people are staying connected and staying in touch with.
Great, thank you. And any other ideas or creative thoughts to share with our audience?
I'll just add, I think back to when the pandemic started and we were all trying to figure out ways to socialize but distance, and it was still a bit colder then. So as the summer's been ending and fall's coming to an end, we start thinking, oh, like all of that's going to get cut off. So we've been trying to creatively think about how do we go back to those drive-by conversations where we'd find parking lots that we could park, 6-12 feet away, roll down windows, but be in the warmth of the car, but still, visit. So I think it's just going back and again, working with everybody, to figure out how do you do it so it's comfortable and where you don't have to cut everybody off from one another.
Great, thanks. Bob, were you jumping in there as well?
I was just going to mention that, actually coming up, we've got the holidays, and the holidays are going to be completely different, and it can be something that's going to be, potentially very difficult for folks. That's one of the things that we're trying to compile a lot of these really great ideas, and actually are trying to encourage the idea of Friendsgiving, that not just for family, but reaching out to those who are caring for someone and they may be feeling isolated, that even if you can't see them, and I love the parking lot idea, I should say that, maybe you find a way to maybe cook together from a distance, and really trying to support folks. I think the holidays are going to be tough and very different for us this year.
Yeah, thanks. I think this is absolutely just demonstrating the overlap of the caregiving and the mental health challenges. And it's not just about getting people to their physical health appointments, but really making sure that there's some of those social connections, especially for those of us who experience winter and are looking ahead. We have another question, and I'm certain my friends at AARP have thoughts on how can we provide healthcare to the 50+ populations in an equitable manner, keeping in mind those with multiple intersecting identities in addition to their age.
I may actually prefer first to leave, because I think certainly the pharmaceutical, the drug cost is a big part of that. Lee?
Yeah, that's absolutely correct. Even if you do have health coverage at this point, a lot of what we're hearing from our members is they still can't afford their prescription drugs. And unfortunately, that can apply to a lot of different healthcare services. It is definitely a challenge to provide good healthcare coverage to wide swaths of the population, but that's certainly something that AARP has been fighting for a very long time, and is why we are very supportive of the Affordable Care Act to the extent that it has kind of strengthened some markets that our members are particularly involved in. And again, we want to make sure that those protections remain in place. So definitely a challenge. Unfortunately, our healthcare system is complicated, and we have a lot of very expensive services that we are using, but we are definitely working to make sure that they're available to everyone, and also affordable.
Yeah. And I would add in, and my perspective comes from where I sit within AARP and the long-term care caregiving side of things, which is that we need to make sure that there are options available to everyone, that are both, they're affordable, they're high quality, but they're also acceptable. And I think the question also talked about, the multiple identities, and that's an issue for so many as we age, is that there may not be the options in my community that are culturally appropriate for me. And so that's really one of the things that we're fighting for, is to make sure that everyone has the options that they want, that are acceptable to them, that are affordable, because that care, that long-term care, that care part of things is a critical part of, as you get older, the healthcare in your life.
And could I just add two quick comments to what both Lee and Bob said is, especially on prescription drugs, I know it's one thing to say it, that people are making choices between rent and or mortgages and buying prescription drugs. But last year in Pennsylvania, and we did it nationally too, but we actually had town halls all across the Commonwealth, inviting people to come and telling us their personal stories about, how they're dealing with the prescription drug prices. And it's one thing to have us kind of say this academically, but when you've had people, 100 people in a room and they're telling you their personal story that they've had to leave, a drug at a counter and walk away because they couldn't afford it. I mean, it's real for people. There really are people out there, and we got to hear from thousands of them last year telling us that they really have to make decisions about, are they going to buy food or are they going to get this prescription? So I have to echo what Lee says about this has just got to be an issue that changes. And secondly, to Bob's point, I mean, here in Pennsylvania, you heard me mention that 68% of the people who've died from COVID have been in nursing homes. And I think that's been a real wake-up call, at least in the Commonwealth, that we have got to do a better job about how people, have their end of life. Either, can they have end of life in their home, which is ideal, which is what my dad's trying to do, or, they've got to have better care in nursing homes. I mean, this has put just a spotlight on the inadequate care we're getting in our nursing homes.
Great, thank you. And that may be part of, Tony, please.
Sorry, Emily, just wanted to add, just from the perspective, I mean, we see so many patients who are coming in crisis because they can't afford their medications. I mean, everybody has a story of somebody who died or was in DKA because of the insulin situation. And these things are just incredible injustices that are happening to human beings in our population. And I think, in terms of representation and multiple identities and making sure that everybody is represented properly, it's really being able to, when you get a seat at the table, looking around at the table and who's sitting there, who's making those decisions, who's amplifying the voices of those folks who are the most vulnerable. And I think that's what we don't do we need to do a better job of being able to do that, and having organizational leadership where they're taking an active look at who's on my board, who are making the decisions, so that we can actually drive these policies forward.
Thank you. Thanks for those perspectives. Our next question, and I think I'll maybe ask Tony first, but love to hear from others. How has the pandemic made us rethink wellness versus illness care, and how can we, switch that thinking in the future around, wellness and sick care?
Well, I think if you're in public health, if you care about public health, you're always trying to figure out how you can maximize wellness over illness, because you don't want them to get there. We don't want to have to treat the crisis, right? We want to be able to prevent the crisis. It's so much more cost effective to do that. And so I think for me, I can only speak for myself personally. I don't think it's changed my mind at all. If anything, it's made me more vigilant about wellness care and making sure that people are in a position where they're healthy and not going to be vulnerable to something as devastating as COVID can be.
Yeah, can I add in on that, Emily? I mean, as you know, I used to be with the U.S. Department of Health and Human Services when we, implemented the Affordable Care Act. And as you know, prevention was such a cornerstone of the Affordable Care Act, preventive services. And I do think this really highlights for everyone what we're going through now, how important prevention is, vaccines, exercising, staying at normal weight, keeping diabetes under control. So, I really want to say, I hope we make sure we really give more, we really speak more. I don't think I used to be a public health official for 30 years. I don't think we ever get the message across well enough about prevention and what an important role that plays in people's lives. So I do agree with Tony that I think, going forward, I hope, think like even in this country, only 65% of people get their flu vaccine, right? So, just making sure people do all the preventive measures they can to make themselves stay healthy so that when, something happens, they're in better shape to survive something.
Absolutely. Thanks for that. Another question we got is, do the panelists have thoughts about changes that can be made to Medicare and Medicaid to improve services and provide supports to elderly and or low income people? Bob,
well,
do you have?
I was going to say, I don't want to keep being monopolizing here, but I mean, just a couple of quick thoughts because I'm living it with my father, right? And actually I sit on a Medicaid managed care board. So the two things I would say is, I think we've really seen the importance of home health care, telehealth, visiting nurses. I hope we can get to a place where doctors actually come back to the home because we know people want to age in place. Even again, seeing the experience with my father having been in the hospital, I saw how much he was able to recover because he did get home health services. But I think, there was a very limited amount of home health services. And I think, expansion of that, making telehealth, permanent. By the way, this is my personal opinion. I'm not speaking officially, the AARP point of view on this, but in my own personal opinion, I think we have to make telehealth permanent and actually increase the services people get at home, including things like transportation that people really, a lot of people really need transportation services to get to their doctor's appointments. I don't know what my dad would be doing right now if I wasn't taking him to all his appointments. So there's just a couple of comments I would make about changes I think we need to make.
And I would echo that. With Joanne said it much better than I could. But we look at it from a consumer standpoint and what they're telling us, and just data that we're going to publish in another week or so. 93% of those that we talk to over the age of 40 say that they really want to be able to stay in their home as they get older, but they're not taking the steps to do that. So more that we can make it easier to do that, and everything from telehealth to being able to have that option to be able to, instead of going to rehab in a facility, to do it at home is really going to help, because that's what individuals want.
And Bob, if I can add, I think where plans do have those programs, and many do, I think we need to do a better job of people understanding what their benefits are. It's hard to navigate, even if you've been in the business for a long time. If you've not, it's next to impossible. So those programs all need to be really set so that the communication and the orientation to what is available to you is at your fingertips when you need it, not when you sign up for the benefit only.
That's an excellent point. I
Yeah.
agree.
Okay.
I would agree with all of those sentiments. And, at City Block, our care model is actually based on everything that you guys have talked about. We have community health partners who are representatives of the community who go out to the home, call folks on the phone, and try to build that bridge of trust so that we can get to them from the medical and behavioral health side and provide those services and make sure that they have the social services that they need, providing transportation to get to their appointments, making sure that they understand what they need to get to an appointment and what do they need to do after an appointment. You would be surprised at how much of how much the gaps are with people going to their appointment and then coming away, they're confused. And so making sure that people understand that, and you're meeting people where they are. And agree, Joanne, with regard to making sure people are at home. You know, you were saying the getting the doctor back in the home. That's what we do at City Block, is we go into the home and we take care of folks in the home with and see them and do our full physical exams, and making sure that their home is safe, and making sure that they don't need any other type of devices to help them walk around. And so I think we need more of that, right? We need more flexible healthcare and meeting people where they are, as opposed to this stringent, protocolized, this is the way we do it all the time, and this is just the history. It's time to shake it up.
And you know, Tony, Emily, can I add one more thing? I want to agree with something you just said wholeheartedly. I mean, you know, my dad would not understand his doctor's appointments if I weren't with him and, you know, taking notes and explaining it later. And, you know, not everybody has someone who can go with those. So I really wish we could come to a place where either Medicare, especially, would have a program where you get assigned almost, you know, someone who goes with you into the appointment and, you know, either takes the notes for you or, you know, make sure you understood it, follow up with you later to make sure you understood what happened. You know, I just have seen way too many times where older people go to a doctor's appointment and they couldn't hear what they were being told. They don't understand what was being told. And so that affects obviously their health outcomes, you know, including medication. The last thing I'll say is, you know, if I didn't put my dad's medicine in a box with each day on it for AM, PM, etc., and then look the next day to make sure he took it all at the right time, he would absolutely not be adhering to his medications properly either. So I just think, you know, we really fall short in understanding that older adults, you know, really need much more assistance to stay healthy than we're giving them right now.
Well, thank you. Thanks for this great discussion. I know we had a couple more questions we didn't quite get to, but we're right at the top of the hour and want to be mindful of our time. So I really just want to thank everyone for joining us this afternoon, and special thanks again to all of our speakers and to our sponsor, AARP. As a nonprofit organization, we are work like we shared today with all of you, relies on the donations that we receive from individuals, foundations, and businesses. If you would like to join our community, you may make a gift directly on our website at United States of Care. And you may also find other resources, including what we discussed today, the Guide to Humanizing COVID-19, as well as a slew of other resources around the pandemic response at unitedstatesofcare.org/COVID-19. Please follow us on Twitter and other channels at US of Care. Thank you again, and have a great afternoon.
Bye.
Thank you.